Okay, good afternoon, everyone. I think we'll make a start. It's just after 3 o'clock, and it all seems very once lopsided today, doesn't it? For those that don't know me, I'm Mark Sutton. I'm the Cabinet Member for Children and Young People, and here at Staffordshire, and I have the role of chairing the Staffordshire Health and Wellbeing Board. Instead of going around the room asking people to introduce themselves, because I think most people know themselves, when you speak for the first time, if you could just explain who you are and who you represent here, I think it just helps everybody understand, and particularly the presenters, when any of the presenters turn up as we go through the meeting. So first of all, we'll start with the routine items of apologies, please.
Thank you, Chair. I've received apologies from Claire McIver, Jill Heasom, Phil Pusey, Ian Reid, Rita Heseltine and Rachel Gallier.
Thank you, Liam. And then secondly, we go on to does anyone have a declaration of any interest at all? No, that's a big fat no. And then copies of the minutes of the previous meeting have already gone out. So are there anything there? I've got a couple of matters arising. Does anyone have anything for accuracy or matters of arising? No? Okay, so the matters arising that I did want to mention was to do with the item that we had on the agenda last month, which is the last time is update on the joint disability and neurodiversity strategy. We've received a little bit of information from Nicola Day, who, if you recall, came along and presented. So the actual joint disability and neurodiversity strategy for 2023 to 2028 has now been drafted. It goes to the County Council Safeguarding Overview and Scrutiny Committee on the 15th of June, next week, and then will be presented for final approval on the 19th of June at the Cabinet meeting here. And that's the update on that. And yes, and also, yeah, as Vice Chairman just pointed out, it also goes to the Integrated Care Board as well for their perusal and hopefully approval. Questions from the public? I don't think we've got any, have we? No, thank you, Liam. In which case, then, we can move on to item 2, which is the Better Health Staffordshire update, and I'm just trying to drag this out a little bit, until Tony turns up. He doesn't think he's coming online, does he, Buncher? No. Welcome, Tony. How are you?
Feeling very apologetic. I thought I was on the 10th.
let's not worry about that. So before I ask Tony to do the presentation on Better Health Staffordshire update, what we do for those that aren't aware, the 4 priorities, we take a look and have an update of one of the priorities at each meeting, so that throughout the year we'll have had an update from all of them. So Tony, the floor is yours. Better Health Staffordshire update. Do you have a presentation or not?
No, I'm just going to talk
okay.
to the hopefully yeah, apologies for being late, and thanks for everyone who helped to prepare the paper. And Tim, I think you're the sponsor, aren't you, for the Health and Wellbeing Board, who's helped to review what we've done. So Better Health Staffordshire, for those who aren't aware, is the brand name effectively that we've given to the obesity work that we're doing, our healthy weight work. It's essentially a two-part programme, a short-term and a long-term. We recognise that there's no quick fix answers to obesity. I think as everyone's probably aware, and doesn't need me to go into detail, obesity rates for young people and children are going up nationally and locally, and it's a complex issue with no straightforward answers. So Better Health Staffordshire is trying to set the foundation for a long-term approach, not dissimilar to what we've seen with smoking cessation over the last 30 years. I think, as probably most people are aware, about half of adults smoked in the 80s. Prevalence rates now are around sort of 12-13%. That huge change that probably seemed unimaginable 40 years ago was achieved through lots of different interventions, changes in legislation, changes in service provision, and cultural changes, the changes to packets and advertising, and a whole range of different things. I think we're embarking on something similar with obesity. And so Better Health Staffordshire is about setting up that foundation of creating partnerships. No one organisation's got all the answers to this. Lots of organisations can benefit from people losing weight. So obviously it's not just about what people eat, but exercise, which is obviously good for people's physical health, mental health, increases productivity rates in employment and education, can reduce crime, antisocial behaviour, drug and alcohol use. There's a whole range of benefits to lots of partners, and every partner's got a role to play. So the basis of Better Health Staffordshire is developing the partnerships in each of the districts and boroughs. To do it once across Staffordshire, we think would have been far too big a geography and wouldn't reflect the nuance and the assets and the opportunities that are available in each of the 8 districts and boroughs. So it's a fairly sizable task. The other element to it is the short-term quick wins. Obviously, the partnership approach is the long-term strategic kind of framework that we develop in that interventions will fit around. But we also want to have an impact on people's weight now. So there's a whole range of interventions that we, the County Council, have commissioned, that other partners deliver. Together Active is one of the key partners in the group, who's very active, for want of a better phrase, in getting people to move. So there's a whole range of things that we're doing that's in the appendix to the paper to try and help people to lose weight straight away. But the big ticket is the whole system approach, which sounds very grand, but I think broadly is just another way of saying developing partnerships, looking at how partners interact with one another, how the actions of some partners can negatively impact on other partners or positively. So we trialled 3 areas, East Staffordshire, Staffordshire Moorlands and Cannock District Council, using the evidence-based methodology that Public Health England produced. And certainly in 2 of the 3 areas, we've got partnerships up and running and action plans happening. In Cannock, we're nearly there. Some of the challenges with this, for one thing, it's difficult to get partnerships going, as I think as we all know. There are already partners who are delivering activities, and there's some really good work, as we know, in Cannock, through Cannock Chase Can, that people may be aware of. There's an app and a whole range of activities that they've produced. And what we're trying to do is bespoke the process to what's available already in the districts and boroughs. It's not a case of we've got this programme that we want to impose on an area and there's a sort of guidebook about how to do it. We're trying to work with those local partners, understand what's available. We've done asset mapping, citizens inquiry work where we commissioned an organisation to go and speak to residents, to engage them in the process, to understand what they want and to enable them to play a part in leading these. Obviously that takes time to try and find a way of working that suits each of those local partners. And we've learned an awful lot of lessons, made mistakes along the way and refined the process. So we're pretty much there in 3 of the 8 areas. The preparatory work has started in 3 more. So the next stage is Stafford, Newcastle and South Staffs. The team's not, the people who wrote the paper, Chris and Rochelle, are not with us today because they're actually delivering some of the sessions in South Staffordshire to bring partners together. We've got lots of products, data, mapping and the evidence-based things that helps to give partners an understanding of how they can work together and the opportunities that this can bring. So the plan is to stage 2, the 3 areas I've just mentioned. Stage 3, Lichfield and Tamworth, that we hope to have completed by around Christmas. So by January 2024, we should have all 8 areas hopefully up and running in some form. We've got a central team to provide support. The idea is that we've got some specialist staff, and that's across Staffordshire County Council, Together Active, representatives of various organisations. We've got dietitians from MPFT to provide some of that expertise and that administrative support to try and reduce the burden on local partners, but ultimately to hand over ownership to people in the local areas to run it for themselves. So the aspiration, we'll continue to provide some support, but the intention isn't for this to be a centrally led initiative. It's something for local partners to drive for themselves in the long term. So I think they're the main progress so far, if anyone's got any questions.
So start off with yourself then, Tim.
Thank you, Chair. It's more of a comment in addition to what Tony's said than a question, if that's okay. So first of all, thank you, Tony, for the presentation of what's been going on. And I think it's right that we start locally and see what a wide range of partners can do to support individuals and communities in terms of healthy weight management, and to draw on the resources of local councils and other organisations to provide opportunities for people to gain support locally within their communities, and also to take advantages of opportunities for exercise and healthy movement, and to have us all focused on where those join up to help people to make individual choices in their lifestyles. I think one of the strengths of this approach is that it recognises that this is a complex issue, that there are many reasons why people aren't a healthy weight. They're social, economic, physiological and psychological, and we need to address each of those if we are to make a difference. And we need to make sure that, as well as giving generic advice to people about healthy eating, and let's face it, there's lots of that out there, and if just telling people to lose weight it hasn't worked, to just providing people with information about how they can do that helps, but it's not enough. People also need support, and if they can find that within their communities amongst individual like-minded people, and through that also remove social isolation and make friends and things, then that is much more likely to happen. Tony, I think, made a very interesting analogy with the reduction in smoking. And many years ago, when I was a health promotion officer and we were tackling smoking, we were doing the more community elements of it with support groups for individuals who wanted to quit. But actually, a lot of the big difference has been made through government changing legislation to put messages on cigarette packets, to reduce the spaces in which people could smoke, and so forth. And I think ultimately, with healthy weight and weight loss, we're going to also need to call on government to help us with that in terms of legislation, to work with food producers to reduce the amount of fat, sugar and salt and so forth in recipes, particularly where they're pre-made and that people have, and to look very seriously at the issues around ultra-processed food, which not only are often higher in calories, but also in terms of how they're made up, encourage people to eat more later. So there's a whole lot of skills and support that we can provide to individuals and communities, and that's what we're about at this stage in it. But I think there's a secondary stage where we may wish to lobby and work with government to support that longer term change, which will bring bigger results across the country. Thank you, Chair.
Well, in the absence of any other questions, I'll make a couple of comments. Tony, thank you very much for the presentation. And I think the fact that we are doing it district by district, and boroughs as well, getting the districts and boroughs involved in this, because this is, you know, very much something I think is in that place, isn't it? And they can have an awful lot to offer in relation to how that this, you know, this plan ultimately carries on. So I specifically wanted not to ask about that, but ask about whether we are doing this yet or whether we are thinking about, and that's the links with the 0 to 19, the school nurses and education in general, and whether as part of it that those sort of individual, are we trying to target particular areas, or we're going to look at individuals? I'm thinking about referrals that might come through GPs or other parts of the health service and that type of thing. I mean, that might not be now, that might be later on, but I was just interested in that sort of thing, Tony.
Yeah, thanks, Mark. It's an all-age plan, and it was actually initiated by the Children's and Young People's team. So I'm here kind of representing it, but we jumped on their bandwagon really. So Karen Coker's team set this up. So we've got partners that represent both adults and the young people's agenda. At the moment, the services that we've got certainly target those areas that need it most. You know, it's relatively straightforward to target services that we pay for, and we can, you know, we know where the high prevalence areas are, and we can incentivise work in those areas. The partnership work is less straightforward in that sense. I think we're very much reliant on the kind of energy, enthusiasm of local people. And I think naturally most of those initiatives tend to be in the areas that need them most. So we've got a little bit less control, for want of a better phrase, over how some of those initiatives work. But I think we can adapt that with the things that we do have control over. You know, one of the things that we commission through public health, both adult and young people, is the weight management services. And they're very much targeted in those LSOAs that have got the highest levels of need. So there is an element of targeting. And I think we'd want to encourage that, whilst at the same time being led by some of the energy that we have in the community. It's probably worth mentioning as well that a lot of the programmes that we're doing across public health are starting to meet in the same sort of thematic and geographic space to some extent. You know, I think 10 years ago, if we'd come and explain what we were doing in public health, it would be very much about services, contract management, targets, those sorts of initiatives. We've moved much more away from that now, as most people probably know about the Supportive Communities Initiative, but we're also doing a lot about mental well-being. That's very much about partnerships, complex needs, ICON that we were talking about in this room a few days ago, integrated co-caring needs. Most of the work that we're doing now is alongside partners at a district and borough level. And I think what we're trying to do is identify opportunities where they can come together. So we've had some discussions around green spaces. encouraging green spaces is good for encouraging people to exercise, it's good for people's mental well-being, it's good for developing a sense of community cohesion. So I think we're increasingly trying to find ideas that can have multiple outcomes. But again, I think some of the lessons that we've learned from the past, that if we try and impose those sorts of things, they're less likely to flourish. And I think hopefully music to Gary's ears that we need to try and work and draw on the energy that's in the community. If there are organisations that are doing things, particularly in those targeted areas, I think we've got some resources, staff, and there's bits of funding that go with this that we can help local people with an energy to do something to flourish. And I think that's the way forward, particularly, as I say, in those thematic and geographic spaces where the different agendas collide. Sorry, I've gone off piste a little bit there to promote the wider public health programme, but hopefully that answered your question.
Just if you knock your mic off. Julia?
Thank you very much for that, Tony. And obviously, trying to change behaviours, we recognise, takes an awful long time. It's a consistent message across the piece, as it were. And it's good to hear that you're targeting perhaps the areas that need it. And I totally agree with devolving it to districts, to district levels, to communities, because I think that way it becomes embedded and it has a far longer lasting impact than imposed from above. I just wonder, within your process, how we can ensure that all the districts and boroughs take up that opportunity to influence and work with us and work with their communities on this.
I think all partnership working is a challenge, and I think we're trying to be mindful that this isn't a county council initiative. The central working team that we've got, it's got representatives of MPFT, ourselves, Together Active, each of the districts and boroughs that are involved in the pilot stages. So we're trying to encourage that partnership from the very start, that the design of this is produced by partners. We've taken one area at a time effectively to try and understand, build relationships in the area, try and understand what people's motivations and interests are. But I don't think it's not without challenge. Trying to get something off the ground 8 times, which is one of the key challenges we've got in a 2-tier authority, isn't it? It's very difficult to do this. Partners are keen to do it. It's not always straightforward because of a whole range of issues that we often have in the partnership arena. But I don't envisage there being a problem long term. The 3 areas have been enthusiastic and have been supportive of this. We're very nearly there in those, and the 3 areas that we're moving into are supportive as well. So I don't want to pretend it's the easiest process, but I don't anticipate there being any difficulties in the long term. That was quite a politician's answer, wasn't it, for an officer?
Thank you very much for that, Tony. Any further questions? Okay. In that case, the board is asked to note the progress made on the Better Health Staffordshire programme, so that goes without saying, and we're also asked to continue to encourage each of our individual organisations to carry on and support the programme, which I'm sure we all do. So, Tony, thank you very much for your attendance today. Many thanks. Which brings us on to the next item, for which we will be joined online by Chris Bird. And this item is the ICS Joint Forward Plan. So at the last meeting, we noted the Joint Forward Plan guidance at a high level. And so this afternoon we get a more detailed presentation, and we are being asked to consider and comment on this, and to endorse a written letter from the Health and Wellbeing Board of support. So welcome, Chris. Over to yourself.
Okay, thank you. So I can't see the room. I don't necessarily. Oh, there we go. Look at that, as if by magic. Thank you very much. I think Liam has asked if I share my screen, which I'm happy to do. So just bear with me while I do that. That probably means I lose visibility of yourselves, but I've only got a handful of slides. So Chair, you're quite right. This is the ICB, Integrated Care Board Joint Forward Plan. And I think colleagues shared the, as you say, a kind of high-level summary previously. What we've shared is both a short presentation, which I'll take you through just to introduce a little bit more. We've also shared now, I think, version 3 or 4 of the actual joint forward plan itself. That currently stretches to about 100 pages, and I'll explain a little bit why that is as we go through. But it's clearly not the final version. You'll see within the documents that we've produced to you, there are still some drafting notes, and that reflects the fact that the timeline we're working to for the production of the joint forward plan is actually the end of the month, so the 30th of June. So we're not necessarily here seeking approval for the version that you've seen today, but just to have a conversation about any areas that you think might need a review as we work towards the 30th. And then, yes, in between times, if we could work on a supporting statement, that'd be wonderful. So hopefully you can see my screen. The first few slides, and these came out with a pack, so I won't stick slavishly to them because I think colleagues have had a chance to review them, just provide a little bit of information about kind of what the JFP is and where it sits within the NHS planning guidance. So colleagues may well be aware that the ICB as a new entity is required to coordinate the publication of 3 planning documents: the ICP strategy, which, as the name suggests, is routed through the Integrated Care Partnership Board, one of the co-chairs of which is Councillor Alan White. The 1-year operational plan, which is a document about how the NHS and its local partners will achieve the kind of mandated operational and delivery targets that are set for us each year. And then the joint forward plan kind of sits in the middle of those. So it covers a 5-year period. It needs to be refreshed every year, and it needs to put a bit more meat on the bones in terms of the ICP strategy about how we will start to deliver some of the ambitions within that strategy. There's a series of principles which I think colleagues will have seen. It's the last but one of those which is probably the key test to us, which is that as a minimum, we need the JFP to describe how the ICB and its partner trusts, so for our system, that's North Staffordshire Combined Healthcare, Midlands Partnership Foundation Trust and University of Hospitals North Midlands, but we have reached out to wider partners as well, including both local authorities and those neighbouring trusts which have a footprint in Staffordshire, so Royal Wolves and University Hospitals Derby and Burton, to describe how we arrange or meet the health needs of our local population. But we have, as I say, set that as a minimum. We have wanted to go further, so I would like to say I've done some fairly extensive engagement with local authority colleagues in various routes around how we can set out ambitions around both health and social care. Detail here about what the joint forward plan is. I won't necessarily go through it in detail, other than to say in preparing and revising JFPs, there is a statutory requirement on the ICB to involve the health and wellbeing boards in the area of the integrated care system. So that's both Staffordshire and Stoke-on-Trent. We must publish, there's a duty on us to publish a draft of our JFP to you as the Health and Wellbeing Board. The Health and Wellbeing Board is expected in the guidance to share its opinion back to us, and we must include that opinion within the final version of the JFP. And as I say, we're building over the next couple of weeks to be able to do that. I'm just going to move my screen around a little. So what's in it, as I say, it's 100 pages, which is obviously quite an extensive document. And that reflects two things, really. It reflects the fact that there is a series of legislative requirements which we need to include within the JFP. So the national guidance published to us includes 10 pages actually of the things that we need to include in every JFP. So each ICB in England will have included those areas. So that's things like workforce and finance and performance, but also how we'll deliver particular duties around things like climate change or diversity, say, for example. So there's a kind of bare minimum that we need to include, which obviously brings a degree of weight to the page numbers. But in doing that, we didn't want to kind of hit the target and miss the point. So we've tried really hard working with partners across both health and care to make it a meaningful document for us locally. I think colleagues will be aware that as an ICS, we have a series of priorities and we've wrapped what we call portfolios around those. So that's things like planned care, unplanned care, mental health, children and young people, and so on. And so within those 100 pages, 50 of them, so 50% of the document, has been given over to the work of the portfolios and how the work and the priorities of those portfolios delivers our kind of legal and statutory responsibilities, but also plays to how we will deliver our ambitions through the ICP strategy. This is just a short slide just to say that in developing that content, we have sought to bring a degree of coherence to it, so that whilst the content may be different, it's structured in a kind of logical way that runs through kind of what our commitment is, why it's important, what we're going to do, and how we will know we're making a difference. Just bear with me one tick. Stakeholders and involvement. So there is, again, a responsibility on the ICB to engage with stakeholders beyond the statutory requirement to engage with colleagues at the Health and Wellbeing Board. And we've done that through various different ways, including 3 webinars, including one that was public facing. We've also engaged with the ICB patient council to seek the wider views of not just partners and stakeholders who will obviously have a vested interest in the plan, but equally with kind of wider patient and public participation. And we've also included engagement with voluntary and community sector. And indeed, actually, in response to that, we've included in the latest drafts a series of case studies, which we think probably better illustrate the changes that we're trying to make in bringing this JFP to life. This is probably quite an important slide for you as a Health and Wellbeing Board, I would suggest, because it's a schematic of how we've tried to align the health and wellbeing strategy priorities of both Stoke-on-Trent City Council and Staffordshire County Council through the ICP strategy and its priorities and into the work programmes of the portfolios. And then, as I say, within the JFP, about 50% of its content is given over to the work of those portfolios and how, in progressing those work programmes, we deliver both the ICP strategies, but also contribute towards the health and wellbeing strategy priorities. A lot of the content, if people have read the JFP, will not be new. Actually, it draws its inspiration from, unfortunately, the fact that we have some sustained health inequalities in parts of our patch, from the NHS long-term plan, which is some years old now, and it also draws its inspiration from providers' own multi-year plan. So a lot of the challenges that we articulate within the JFP, I think, will be reasonably well known to colleagues. What we've tried to show as being different is the approach in responding to those, rooted in prevention, rooted in early intervention, rooted in collaboration and integration across both the NHS, but in particular with local authority colleagues. We've just suggested some draft language that the Health and Wellbeing Board may want to consider in terms of sharing their opinion back with us. It is, of course, entirely up to the Health and Wellbeing Board in the language that they want to choose. And then last but not least, just to confirm the timelines that we're working to. So obviously here today in Staffordshire, the document will go to the ICB board next week. We will be seeking, delegated approval to the Chief Exec and the Chair of the ICB board for any further amends through to the end of June, and then at the end of June we will need to publish the final document. It is perhaps just worth saying as a final note that at various stages along the way we have had feedback from NHS England. They're ultimately the arbiters of whether our JFP meets the legislative requirements that we've been asked to be mindful of. That feedback has generally been positive. There are some areas where they wanted a bit more weight of emphasis brought to, and have responded to that in the latest version. But perhaps, as I say, just worth saying that there is a kind of oversight and regulatory element to the JFP, which again will be confirmed in the last 2 weeks. So I'll stop sharing my screen, and I think I shall appear on screen for you locally, and happy to take questions and comments.
Okay, Chris, thank you for that. I see what questions that members might have, and I'm sure Julia will have some, because I saw her busy scribing. After Julia, yourself, Gary.
That's very kind, thank you. Hi Chris, Gary Jones from Support Staffordshire. We've had quite an extensive ongoing dialogue about VCS in sort of how that's reflected in the plan and particularly some of the portfolios. So I won't go back over that here. It's kind of, I think, constructive, positive, ongoing dialogue. My question relates to a different element actually, which is you made reference to the fact that the 2 provider trusts in the south, the 2 acute trusts, are not directly listed in the plan. Is that an NHS England requirement that they can only be listed in one plan? And I'll just say why I think it's a bit problematic. There's already a perception in the south of the county that the south does less well as compared to the north in terms of NHS investment, and the absence of what they will recognise as their hospitals only serves to reinforce that message. I mean, I don't know that the general public is likely to probably read this plan, but even for the professionals that do, when you read that page in the plan, it looks like it's about 2 of them which are very much the north, and people probably don't necessarily associate MPFT with any particular geography, but it's a bit glaringly obvious that their hospitals, Cannock, Lichfield, Tamworth, Burton, appear to not be given the same status in the plan. Thank you.
Yeah, so Chair, I can only see Gary on screen, so I don't know if you're inviting me in to respond to that bit, but I'm more than happy to do so. So hi, Gary, didn't realise you were in the room when I was talking about the VCSE aspect, but great that you are. So yes, it's exactly that. So from a NHS England planning perspective, they effectively force fit a one-to-one relationship between trusts and ICS areas. So from an NHS England perspective, the Royal Wolverhampton Trust is considered to be part of the Black Country ICS, and UHDB, University Hospitals Derby Burton, considered to be part of the Derby and Derbyshire ICS. That said, you're quite right, and I think I said as we went through that we had made efforts to make sure that the voice of those partners was represented. We're acutely aware, pardon the pun, that Cannock Chase Hospital, Burton, Queen's and Lichfield, Samuel Johnson and Robert Peeler are essentially run by trusts that are headquartered in other ICBs, but nonetheless serve the patient population of Staffordshire and Stoke-on-Trent. So I think we have made strides to include that. I'm happy to have a conversation of if there's a bit more, as I say, kind of weight of emphasis that we might need to bring to that.
Gary, did you want to come back on that at all?
I think it's just that what you said really. It's that emphasis, isn't it? When if you haven't got time to read the whole 100-page document, you tend to kind of skip through and look at diagrams, and there's a diagram there that shows the other 3 and doesn't show those. So I don't know if there's a way that you can reflect them in that diagram on page 9 a bit more explicitly. I think it might be helpful.
Yeah. Okay.
Julia?
Good afternoon, Chris. I don't know whether you can see me.
Hi.
See
Yes,
you.
I can see you. Yeah.
Hello. Obviously, I think the aims and objectives of this plan you can't argue with. It is a 5-year strategy, and in terms of some of the technologies available to us in 5 years' time, not sure what that will be. But there are a couple of issues. One is on page 57. It's page 79 on our set of documents. It refers to, there will be an annual increase in workforce numbers, and it goes into more GPs, general practice nurses, etc., etc. And a lot of the plan is based on the assumption that that human resource with those skills and those numbers will be available. Now, the NHS has fallen over a little bit on this before, because with the changing demographics of our population, we've got certainly increasing demand because of a lot more older people as a proportion of the population, and a lesser proportion of younger working age people coming forward. In terms of GPs, over the years, more GPs have been trained, but they're not delivering any more hours because so many of them are working part-time. And I just wondered whether it's not so much a people count, but how many hours of additional service. And I'm not sure that you can make the assumption that that's always going to be available, that you're automatically going to get more GP hours. And I think the document should be specific. It's not about people. With changing working practices, with people tending to look for shorter working weeks, more flexible working, as I say, the availability within primary care has not panned out as was originally planned 20 years ago, and bearing in mind it takes, 7 years to train a GP. The GPs are there, but they're not producing the hours of work that was originally envisaged. So in a 5-year plan, I think it needs to be the number of hours available will increase. But I'm not sure how deliverable that is. And linked with that, there's many references in the document to digital. And a lot of it, I think, is reference really to having access to information online consultations. So it's more that online link, whereas actually digital is a lot more. And I would have perhaps liked to have seen a little bit more in terms of emphasis on using assistive technology and reference to AI, very much in the forefront at the moment. But there is huge potential in AI, whether it's initial assessments or actually enabling you to employ the workforce in a more productive way. As a 5-year plan, I think you need to recognise that these technologies are coming on board stream very, very quickly. But I think the reference to digital is a bit too narrow in this document, whereas actually it's far broader.
Chris, did you get all that?
I did, yes. So thank you, Councillor. And I mean, I think we'd take those comments on the chin. Actually, I think they're well made and well put. So I think we do need to, as I say, we do need to slightly bear in mind that there is a kind of oversight and regulatory element to this that's run through NHS England, and the established metric for measuring GPs is usually whole-time equivalents or its appointments. And we actually, I think we're due at scrutiny on Monday, actually, with your colleagues, and we have got some data there that will show that the level of appointments delivered through primary care is both in excess of the annual plan that we had for 22-23 and for 19-20, which is the last kind of comparable year, bearing in mind the pandemic in between times. But nonetheless, I take the point. So I've got experience of integrating mental health services with primary care and moving to that kind of salaried model. And there was a kind of change in the dynamic of the workforce arrangements as part of that. So I understand the point that you're making. And as I say, we need to balance out that regulatory and oversight element with it being a meaningful document for us locally. So we'll certainly take both that and the comments around online versus digital away and try and reflect that in the further iterations between now and the end of June.
Okay, thank you for that, Chris. Any other comments or questions? Richard?
Yeah, just because of the document's relatively high level, but could you tell us anything about the development of more specific action plans and sort of, I suppose, resident-facing metrics? So if you take the primary care example, an individual person doesn't really care that there's been 5 million GP appointments. What they care about is their GP appointment. So how long has it taken to get it, and has it fixed their problem or not? So there's something there about time waiting and something about the quality and their experience. So and that's the same across all the portfolios actually. So that what NHSE measure isn't necessarily what people are interested in. So is there a bit of work going on underneath this to sort of get into some of the nitty-gritty of that?
Yeah, thank you, Richard. Again, I think that's a fair point. It's a 5-year plan, which, as I say, is designed to put a bit more flesh on the bones around how we'll start to deliver from an NHS and care perspective the aspirations within the ICP strategy, but it isn't in and of itself designed necessarily to provide specific detail about all elements. I think we'd quickly get over to 1,000 pages at that point, wouldn't we? So primary care is a good example where the ICB at its meeting in April published the GP 5-year strategy, which sits then in this wider context, and that is the delivery vehicle through which we will deliver what's called the Fuller stock take. So this is a national review done by a lady called Dr. Claire Fuller in 2022, in which all ICB systems have been asked to develop a local response to, and that will pick up things like ensuring there is same-day urgent care access, there's better personalisation of care, we can integrate health and care services at local GP level, and that's now been complemented by the National GP Access Recovery Plan, which was published a couple of weeks ago, and colleagues may have seen that. But that's the vehicle then that will be able to drill down to kind of PCN level, which is primary care network level, which are groups of practices working at generally a population of about 30 to 50,000. There's 25, 26 PCNs in Staffordshire and Stoke-on-Trent. The vast majority of them are aligned to district and borough footprints, and it'll be through those mechanisms then that we do start to kind of take the high level aims of the JFP and start to kind of root them into something that might be recognised more by local communities.
Tim, sorry, before we do, Richard, did you want to come back on that at all or not? Tim?
Richard's picked up on an area that I was going to raise and interested in Chris's response in that. I just wonder, in terms of primary care, it's such a critical part of the pathway for people to access services more broadly, acting as a gatekeeper, and is clearly a system under great pressure at the moment, in part due to the pandemic, in part due to all of the other issues that you mentioned. Clearly there's a national look at how that's working, how effective it is, and how we can recruit GPs, and that's welcome. But I just wondered whether there is an opportunity to look at the model and just see if there is a different way of both treating people's more minor health concerns and providing access to the broader health system, because it seems to me we have a model which has been in place for a very well, since the beginning of the NHS and before, and maybe there's time for a more radical look at that. And do we need to wait for that to be a national thing, or is that something where we could look at things more locally? Thank you.
So, thank you. So again, within the GP 5-year strategy that the ICB board has recently published, and I'm happy to send a copy of that to colleagues if they're interested. It does set out the kind of mechanisms for how we'll respond to some of those challenges that Tim outlines. So I referenced PCNs. So PCNs were established about 3 or 4 years ago. At the same time, and it's grown over time, but at the same time, there was a number of posts to augment the PCNs, which were called Additional Role Reimbursement Scheme, or ARRS. The NHS loves the acronym. And those were to fund posts like first contact physios, first contact pharmacists, mental health practitioners within general practice, often at that PCN level, so not necessarily at individual GP practice level, but at the PCN level, to be able to ensure that patients can get kind of right access to the right clinician at the right time, and move away from, you know, the only route into general practice being to see a GP. So we've done a lot of that work. At the same time, there have been other developments. So in order to promote access, there are some services now that we can do at home. So remote blood pressure monitoring, for example. We've also been working with pharmacies to refer patients from general practice into pharmacies. We're the highest referrer into the community pharmacy scheme in the West Midlands, as it happens, and that's another feature of the National Access Recovery Plan. And then there are a series of actions within that national plan that local systems need to respond to. And I think the one that will probably gather most attention is around changes to digital telephony within general practice, because that is the mechanism by which we'll move away from what I call the 8 a.m. scrum. So that really frustrating experience that I know many people have of trying to contact the GP practice first thing in the morning, and we are required to as a local NHS have statements back to NHS England about not only how we will respond to that, but the progress we're making. So again, I think that'll go some way to do that. And we have now been able to establish analysis at kind of individual GP practice level that we can slice and dice in different ways, whether that's through PCNs or districts and boroughs, for example, so that we can see that whilst the headline measures may be really good in terms of the number of GP appointments, we know that masks a degree of variation, and some of that variation is concentrated in 1 or 2 areas, and there's more work we need to do with the practices to understand and unpick that.
Tim, carry on.
Thank you. I just thank you for the response. I can absolutely see the attraction in using pharmacists for some procedures and so forth. I think we need to just be a little careful with that to make sure there aren't unintended consequences whereby if somebody went and had a service from the practice nurse at one point and now goes to the pharmacist but then finds themselves paying for it, we need to just make sure that that doesn't discourage people from getting the treatment that they need. And just one comment, if I may, Chair, just in general, welcome the commitment to working in partnership with people and communities. And I think it would just be interesting to see how as this unravels or rolls out, I should say, how wide that consultation and involvement becomes in terms of the services people receive. Thank you.
Thank you for that, Jim. Any further points or questions at all? Okay, so there doesn't appear to. So, Chris, thank you for that presentation. So the board is asked a number of things. Note the process and progress made to develop the joint forward plan since the last Health and Wellbeing board meeting in March of this year. Obviously receive the draft of the forward plan and endorse a written letter of support from ourselves reflecting the draft high-level wording in the attached slides, but then goes on to say that if we can't do, in effect, if we can't do that now, gives me delegated authority, asking for me to have delegated authority to sign that letter before the final publication on the 30th of June. So, Chris, my question is when will the actual final document be ready if members of this board have got any reservations about signing a letter or having a letter just at this moment in time?
Yeah, it's a good question, Chair. So we are just in the process of publishing the most recent version to the ICB board, sorry, get me plosives in the right order there, ICB board. So that is a week today. I'm sure there'll be comments and questions arising from the review there. That will augment some of the conversation we've had here. So by the end of next week, we hope then to publish the revised version. That will come to you as Health and Wellbeing Chair, obviously make it available to the board as a whole, but it will be that version that we'll be seeking to solicit your opinion on, if that's okay.
Yeah, understand that. I wondered if the points that we've raised today round the board, which of those people, which of those that members of the board would see as something that they would essentially like to see in that final plan, if there was anything in particular. I wondered, Gary, if you were looking to see anything on that diagram at all, and whether, Chris, that's a possibility. Or are we happy when we get that to circulate it, and if there are, unless there are any major things, that we would endorse it? Chris, is there anything that you've picked up from today's meeting that you feel that you're going to be in a position to be able to have included?
So I think there's certainly something about, as I say, I think we have taken some strides to make sure that we've reflected the fact that we've got two major trust headquarters outside of Staffordshire that have an impact in Staffordshire. So I'll need to reflect on that, I think. And then I think Councillor Jessel's point about the workforce and the perhaps overly narrow definition of digital is something that we'll want to take away and reflect on as well.
Julia, you got a question?
If I could make a suggestion, Chris, to make life easier for all of us, would it be possible, if you make any amendments, to send the document through with tracked changes? I don't recommend this for bedtime reading a second time round, but if we could have a document with tracked changes, then we can make a decision if it can be circulated to the Health and Wellbeing Board. We could feed back to the chairman that we're happy with the changes, and then it will make it a quicker process for you, bearing in mind you're up against a fairly tight deadline. Yeah, I think track changes might be difficult, if I'm being honest, Councillor, just because of version control. But what we could do is do at the point we send it back out after ICB board, if we issue it with a covering letter just drawing attention to the sections that we've updated. I think that might do the same job but in a slightly different way, if that's okay. It just helps us retain version control. Yep, I think that would be helpful to everybody. Yep. And then on that basis, I'm happy to propose that we give delegated authority to you as chairman of the Health and Wellbeing Board to sign off a letter.
Okay, Julie, thank you for that. Is that proposal from Julie, is everybody happy with that? Yeah, I think everybody's happy with that. So, Chris, thank you very much for your presentation today, and we'll follow that through and get something to you by that deadline day. Okay, thank you all. Cheers. Bye. Okay, so if we move on to the next item, which is item 3, which is the co-production of the Health and Watch update. Bas, that's yourself. So over to you.
Good afternoon. Yeah, thank you. My name is Bas Tamise. I'm the manager for Health Watch Staffordshire. Today I'll be giving an update on our Year 1 progress to reflect, and it's reflected in our annual report, which is currently on our website. It's also reflected in the report submitted, which I'll take as read. I will be going through some slides to pick up the key highlights. I'll also be going on to talk about our end-to-review power and how we are working with NHS partners and trusts to do joint interview and quality assurance visits, talk about systems change, and then finally to our last slide, which will be around the year 2 priorities and our deep dives. Healthwatch is your health and social care champion. As an independent body, which is statutorily required across England, we have the power to make sure that those making the decisions listen to your feedback and improve standards of care. It's really important that you share your experiences, whether good or bad, happy or sad. We use your feedback to better understand the challenges facing the NHS and other care providers, to make sure your experiences improve health and social care services for everyone. We can also help you to get good quality information, advice and guidance, signposting and appropriate services. So just to highlight that we predominantly are set up as a feedback, information, advice and guidance, and then signposting. And we work with partners such as Assist, who will help with advocacy. Oh, sorry. Yeah, apologies. Okay, so this is the Healthwatch team at the moment. So we have Emma Ford in the north, we have Dave Bassett in the southeast, and then we have Daniela Ballantyne in the southwest. We have Christine Sherwood, now, who's the social care engagement focused officer. We have predominantly four part-time officers. They do cover big geographic areas. However, if you do need to get hold of any of us, we are on the website, and I'm happy to share any of their details if there is more of a local focus for anybody. And we also have Claire Hill, who is our data analyst. The way we are finding how it works best for us within the Healthwatch is to differentiate between the two. So there's our ongoing reactive work and our proactive work. So within our reactive work, that's our day-to-day in the round, what we pick up through our free phone number, email, face-to-face, could be via the website, events, online Zoom meetings and groups and teams. We also have our proactive work, which is our ongoing 3 deep dive areas. The focus there is around access to primary care face-to-face, being a seldom heard, so those groups or communities that are hard to reach or don't often have their voices heard. This includes the LGBT focus. We also have our 3rd area of deep dive, which is the root causes of good and poor teenage mental well-being and health outcomes when you've been in care as a child. So these 3 focus areas we will be concluding in early November this year, and we'll be presenting those findings at that point. We also have been working on our Enter Review, which is our statutory power. With Enter Review, it is a power that we do not necessarily have to give a reason why we're going to be doing a spot check or a visit. It's just, it could be simply that it hasn't been done for a while and we need to do, or it's good practice to do one. Or it could be based on feedback. And now we've further progressed that to work jointly with the quality teams within MPFT and UHDB to ensure that we are doing that independent inspection as well, which is also helping us to get into those areas that otherwise could be more difficult, and I will explain a little bit more about that as we go on. And then finally, we have been building on our Healthwatch Intelligence Network, which is made up of members from the VCSE sector. We're quite fortunate that we're placed within Support Staffordshire. That's helping us to already tap into the existing networks that Support Staffordshire has built up, saving Healthwatch a lot of time and energy. So as part of our reactive work, so the key findings we have been getting back is lack of access to primary and secondary care, and then at points of discharge. What I would like to just highlight as being the critical friend here as well is just to say that when people do access into those services, the treatment generally is very positive. 90% of the feedback is people saying that that was very good or fantastic. So the issues seem to be around the access points. What we do find is that people do still complain, saying that they will ring up, they will get put into a queue on the automated machine at 8 o'clock in the morning. As we know, it could be 50th in the queue just to get to the end to be told there are no appointments that day and to start over again tomorrow. Now, we have been working with our partners within the ICS, and we have been looking at the 111 number to help offer that better information, advice and guidance. We have been looking at the digital aspect, but we do recognise that there are some people that will be digitally excluded. We know with farmers, they have mentioned that they don't often get reception in their areas, or they have no access to the internet, for example. We also have been tapping in with the pharmacies, and I know that's been mentioned a little bit earlier on. So far, an example I will give on that is we did have a lady ring in who's a carer for her child, who was really struggling to get an appointment and medication for her child. The engagement officers then did look up the GP practice to find that there was a pharmacy attached to it, and the pharmacy was able to then dispense the medication. And that was then taken back to the carers group, and the carers group found that as a good practice, and that's really helped them with their anxiety and not feeling too distressed when making those calls. So it's just looking at picking up what other ways there are to getting those needs met for people that otherwise would struggle to get the access into primary or secondary care. We have mostly been hearing negative feedback about NHS dentistry appointments. I know there is some work ongoing about that. I'm sure there's going to be some stuff brought up about that with the scrutiny committee next week. I know, having spoken to Tracy Shewan, there will be some highlights on that. People often have complained saying that they have to, travel hours to get an appointment, or they have to take off, a day off work just to make those appointments. Other people say they just can't get any appointments, and they are struggling with that. We did receive over 70 pieces of feedback and patient experience, which we then cascaded back to Health Watch England, who did do a campaign on this, and they also talked to other local health watches, over 30 collectively. I think they collected around or just over 700 pieces of information and experiences, which they took back to Parliamentary Committee on Dentistry as part of the final session on the inquiry into dentistry. So we're waiting for that feedback to come back and the recommendations. Other issues that we are facing as well is around cost of living. There was a campaign done by Health Watch England on this. Some of the things, the people most affected by this were those that were being means tested, or those with disability benefits. They really did struggle with the cost of transport, especially, and those in rural areas. We do recognise, and we have spoken to our partners within the ICS about how we can act a little bit sooner when it comes to the preparation for the next winter, as there will be those pressures coming again. So that is discussions that are taking place. We still have concerns around and hearing concerns around long A&E waiting times in ambulances. We have been talking again within the various trusts about how the initial call handler with 999 can offer different advice, maybe if especially they've been told not to move somebody that's, let's just say, fallen over on the floor and there's a cold surface. Is there any better advice that can be offered rather than leaving there for an ambulance to come? That can sometimes take quite a lot of hours to get there, which can then lead to other complications. There is the NHS ongoing strikes that is further impacting operations and delaying processes there. And then finally, with the delays in hospital discharges, we are still finding that this is an area where, especially with frailty, I know there's a lot of work, and we are picking this up, being done about prevention. That's really welcomed, to help people, to help themselves. However, we know that also there are more and more people now getting frailer and that are ending up in hospital. We have been doing some work around how social care can also support to plug the gap on and help the process of discharge being faster. But there is also concerns around how quick medicines are being dispensed within the hospitals. As part of our proactive work, we have been working with Staffordshire County Council, especially around the care homes. We've done some surveys and interviews across the different districts and care homes and asking the question, what is important to residents in a care home? We found this joint work really productive. It helped us get some insights into key areas around. Those residents generally found those care homes to be very good. They did enjoy where they were staying. However, they would like to have more outdoor time, and they would have more around their religious affiliations, especially maybe going to a church or having a priest come in and see them in the care home. What was really good about this also is that the patient feedback is then being used to help with future care home contracts to reflect the patient voice in that and the social care strategy in 2024. We will continue to work on our 3 deep dive areas, which we are aiming to publish, like I said before, in November. We will continue to build on our Health Watch Intelligence Network. Our joint entrant view and quality visits. This has come about after some meetings that we had with the quality teams within the various trusts. We talked about how we can have that more effective, especially within the NHS. What we found then was that if we did this and we still maintained our independence, so our report is still published independently, what we do is when we do these independent visits, We write up the report independently. We will make those recommendations. We will then pass that back to the trust to make either comment or remedy for them to have an opportunity. And then we will publish that. That will allow us then and the public to see the full process, and then it's easier to follow up if those things have been completed, if they were outstanding. Generally speaking, we've had positive feedback so far. And again, you can find this reflected in our annual report and on our website. What's been really helpful with these is that it does take some effort as well, and energy and time and staff for those services to accommodate for us for a visit. What we found by doing it in this way is that we get access a lot more easier, and we have minimum disruption, but with the maximum output from this. And so far, this has been very welcome. This is now going across to other health watches across in Shropshire and in Derby, and it's been a good way of working and moving forward together. We also have our regular e-bulletins, which reflect our ongoing work. We do recognise that our deep dive projects will take a year from start to finish. So they started in November last year and they will end this November. The good work that's been picked up in those is going to be reflected in those e-bulletins as an ongoing piece of work. And then finally, just to bring back on our Health Watch website, there is the annual report. So again, we are going to continue to build on these joint entry and review visits, picking up with different hospitals and business centres. This has increased for us as a Health Watch as well, the number of entry reviews we are doing every year, and it's also increased the amount we are having those visits in the hospital. Going forward, the themes we do see coming up will be around hospital discharges. Frailty will be something that will still be coming up, but I do know that again, like I said earlier, there is a lot of work going on prevention. Social care, how we can support social care in this, how both health and social care work better together. There will be some work up and coming and a campaign with Health Watch England about social care and unmet need. There will be also further work with Health Watch here, with care homes as well. And then there will be access to primary care and dentistry, that's ongoing. Seldom heard, those in rural areas, so hard to reach communities. And then around the mental health with the George Bryant closure. So that is something that we have been involved in. And recently with St George's, with the CQC report where they have been downgraded from the mental health from good to inadequate. And we have had a meeting with MPFD as a Health Watch, how we can support them with this as a critical friend. And that's the end of the presentation. I'll take any questions.
Thank you very much for that. I was busy making a few notes. Questions, comments? But the ask of the board in this case is to consider and comment on the progress made during 22-23, and also consider and comment on the annual report, and we may wish to view on the progress made within it. So on that basis, do we have any questions, comments at all? Carmel.
You need this, what you just there. Are you aware of the full service that the fire service have set up in December? So we've been commissioned for another year by the Integrated Care Board. So that initially was to cover the east of the county, so Tamworth, Lichfield and Burton-on-Trent. But because of the demand, we're covering the whole of the county now. So we're providing that service 7 days a week, from 8 o'clock in the morning till about 7 o'clock at night. So I just wanted to make sure that you were aware of that. We get the calls from the Care Coordination Centre that are passed through from West Midlands Ambulance, and we respond to what we call green calls, so non-injury calls, to try and stop those long lies that you referenced earlier, because the long lies are what are causing illnesses and further conditions with the patients. So I just wanted to make sure that you were aware of that.
Yeah, thank you for that. I mean, we were aware that the fire service is doing more, but I think the detail is really welcomed.
Okay, thank you for that. In the absence of any other questions, thank you very much for that, Baz. We can move on to the next item on the agenda, which is the Children's Safeguarding Board annual report. Ian is there. So, Ian, it's a good job we didn't have the same technological issues that we had this this morning at another meeting. So, Ian, over to yourself then.
Great, thanks. Thanks, Mark. I'm assuming people can hear me okay. Afternoon, everybody. So my name is Ian Vinall. I am the independent chair and scrutineer of the Staffordshire Children's Safeguarding Board, and I've been in role since June of last year, so June 2022. Obviously, the report that's being presented today was written not in my tenure, but I'm here to present it to you this afternoon. On the papers, you would have received an attachment which takes you directly to the report itself, and obviously you can view that in detail when you need to. My contribution to the conversation really this afternoon is just to kind of highlight the issues from the Safeguarding Children's perspective in terms of the relevance of the board, the Health and Wellbeing Board, and the Children's Safeguarding Partnership. Obviously, you'll see from the documents that are contained in the attachment, in terms of the annual report, how it's structured. So you'll see, obviously, in terms of our priorities, or the board's priorities are highlighted there, which obviously has some relevance for colleagues in the Health and Wellbeing Board, particularly around children's neglect. And I'm particularly interested in terms of the underlying causes of those issues for children and young people in Staffordshire, which obviously has implications and impacts around the role of the Health and Wellbeing Board, including, for example, issues of deprivation, adolescent and child mental health, and obviously any particular socio-economic issues for children and young people around neglect, and obviously the impact of current circumstances for families around the issues that there are around the cost of living crisis and so on. The main priority for the board has been this focus on neglect for children under one in particular, and that came about primarily from some work and activity that was undertaken between 2019 and 2021, which included the identification of a number of child safeguarding practice reviews where there were concerns around neglect and the identification of neglect for children. As a result of that, you'll see from the annual report that there's been investment in the implementation of what's called the Graded Care Profile Assessment Tool, and that has been in place now for several months. One of the things that I'd say to the group is that does require evaluation locally. There's been a significant number of professionals trained in using the assessment tool, but that currently doesn't equate to a particularly high number of assessments undertaken. So we need to do some evaluation of how that's working in practice across the agencies. The other priorities you'll see there in the board annual report include child exploitation, and obviously we have again a collective role to address some of the issues for children in those circumstances where there's extra familial harm that is not harm that is based within the home, but harm that's based within outside of the family home, and the impacts that has for children and young people. One of the other board priorities which is highlighted there in the report is in relation to hearing the voice of children and young people, and it's a key area for me because I think it's really important that we learn from the experiences of children who have been involved in the safeguarding system. And I've been working as the chair and scrutineer with the Voice Project, which is well known to colleagues in Staffordshire, to look about how we can develop that in a much more focused way, which includes innovatively at the moment possibly recruiting some specialist children to be part of a pool of children that have lived experience that can feed back to us about their experience of services and how they've been received. Obviously, colleagues may or may not be aware of the changes that are happening regarding the MASH and the multi-agency safeguarding hub arrangements. Obviously now they are separated from Stoke. Previously were a joint arrangement with Stoke, but now they are separate, and the board, the strategic partners need to ensure that those arrangements continue to be safe during these transition phases. Obviously, that is something that the strategic partners have an ongoing overview of. Just to mention for people's reference, the strategic partners who have a statutory responsibility for the safeguarding arrangements in Staffordshire are Staffordshire Police, the local authority, and the Integrated Care Board. Obviously, there are a whole series of other services and systems that have responsibility for children's safeguarding, and they're known as relevant partners in the legislation, but clearly they have a significant role to play. Included in that, obviously, is in terms of children who are within education settings, and I've made it my part of my priority in the scrutiny work is to work alongside colleagues from schools and learning, and that includes colleges and early years settings. And in that context, I'm pleased to say that I've now set up a working group of designated safeguarding leads in schools, and we had our inaugural meeting a couple of weeks ago, and that had about 35 to 40 designated safeguarding leads from across the school economy in Staffordshire, and they provided some excellent insights and analysis in terms of the experiences that they have around children and young people, and some of the challenges that exist for children currently, which obviously will need to be factored into future potential prioritising for those children. Obviously, another area of practice, which is something that I'm not entirely sure that the Health and Wellbeing Board is cited on, and possibly it might be an opportunity to do some join up around that, is in terms of the local child safeguarding practice reviews. So when a child is sadly dies or is seriously hurt, the strategic partners have a duty to review those cases and those children's circumstances, and there's been a number of commissioned child safeguarding practice reviews in Staffordshire in recent months, and obviously as a result of those, there are some action plans that are developed which should identify the learning that comes from those reviews, and then that should appropriately seep into the agency's network. Significantly, I'm hoping that frontline practice is impacted, and particularly children and young people are impacted as a result of those processes, and it's something that I'm quite keen on analysing as in my role as scrutineer. The last area that I just wanted to mention, or a couple of last areas, is the learning from child deaths. The board has a statutory responsibility to review all of the children and young people who have died aged under 18. And you may be aware that obviously that's the Child Death Overview Panel has a annual report with some learning and themes in that annual report. And I think probably, if it doesn't already, it should probably come to the Health and Wellbeing Board, because it has some quite significant factors in relation to child deaths in Staffordshire. As an example of that, which obviously may link to the priorities for the Health and Wellbeing Board, include children who have died from suicide or deliberate self-harm, and also the issues around what's described as modifiable factors, which have relevance for the Health and Wellbeing Board, which includes smoking, domestic abuse, alcohol misuse, unsafe sleeping arrangements, and poor mental health. So it's a real join up I can see that there could be in relation to those issues. And then lastly, the board has a responsibility for reviewing the restraints that occur in the youth offending estate in Staffordshire, which is Warrington. So the board has a specific role in reviewing with colleagues the restraints that are undertaken at Warrington. And there's obviously a review of restraint group which reports back to the board in relation to those issues. I think as I said, one of the things that I'm keen to do is join the dots, and Mark has mentioned that we met this morning as chairs of the strategic boards in Staffordshire, which I think is a great opportunity to think about how we can share learning and also tie up and join the dots around some of the issues that we're facing around children, young people, and adults and their health. So I think there's some real opportunities to do that, and I'm obviously happy to take any questions from any colleagues if anybody's got anything that they feel they need to ask. But I think probably that just sums up my oversight of the report, because as I say, I don't want to go through it in detail. It's available to colleagues online.
Okay, Ian, thank you very much for that. See if there's any questions from any members of the board. Julia.
Thank you very much, Chairman, and thank you very much for that talk through your annual report. I must admit, when I read it, the one area that caused me quite some concern is learning from child deaths. That there'd been a significant increase, almost 50%, and of the total number of 93, 47 are deaths within 28 days of life. I'm afraid life is such that there's always going to be a certain element, but that seems quite a large proportion. And I was just wondering what mechanism, and this is perhaps to other members around this table, there is of ensuring you've identified some of the key areas of work, pregnancy and smoking, etc., etc. Are we sure as a partnership here that actually all the necessary actions, we're giving them the attention that they need? Because that is quite a startling statistic, I thought. So if through you, Chairman, we could ask, what actions resulting from these, because you always hear on television and news programmes, everybody says, oh, we're going to learn the lessons. Actually, are we convinced that actually we are learning lessons and we're doing everything that we can to make sure that those strong messages go out and that we reduce that figure?
Thank you for that point. Ian, before I ask members of the board, is there anything you want to say in particular?
Yeah, I think there's a very valid point raised around those concerns. I think, you know, when obviously they're, you know, we're currently just in the process of just looking at current data for this annual report this year. And obviously there has been a series of activity and actions that have taken place as a result of some of those highlighted issues. You'll see it, as I say, if members have copies of the child death overview panel report, I think would be quite helpful for you to see what evidence there is there, what action and activities happen to address some of those issues. And some of those, as you know, and quite rightly know, are public health messages that need to go out to the public. So it's a you know, that there is activity happening in terms of promoting certain things like such as safer sleeping and so on and so forth. I mean, we know, sadly, and Mark and I were having the conversation this morning about some of the levels of complexity that exist in children's circumstances now, through all sorts of different factors, I think. But certainly, you know, the access to mental health support, for example, is something that is featuring large, most recently for children and young people. So there are some things that we kind of are aware of emerging that need to be considered. But as I say, there is activity through the Child Death Overview panel and the actions that they take that are trying to address some of those issues. But I don't deny that you know, the numbers are of a concern.
Thank you for that, Ian. I wondered, Neil, I'm not wanting to put you on the spot, but I will. As one of the actual well, obviously ourselves, the police and health are all statutory partners to the Safeguarding Children's Board. But Neil, you actually physically sit on there, so I wonder whether you'd got any particular comment that you wanted to make at all on that point that was raised by Julia, really.
Yes, I mean, it is absolutely true, and we have discussed it at the board as to how come we don't seem to learn the lessons, because certain things, whether that's communication, sharing information, they seem to be consistent features in all the reviews that are published. And one of the methods we've really started using, or our reviewers have, that when they actually do the practice review, they meet with the practitioners who've been involved with the child without the senior managers being there, to be able to really have that dialogue, to almost relive the case and see what happened, what were the salient points. And what we are then doing is building that feedback into a multi-agency training so that it does get embedded. But obviously what we do recognize and accept that some of the situations are very, very complex. Often it's the parents managing to hide the information, being very deceiving in their interactions, and we sometimes do lack that professional curiosity to look beyond the words. So it really is that constant work in progress, learning lessons, making sure that people do feel confident about sharing information and really talking to each other. But there are no quick fixes, because, we've seen from national reviews about Star, Hobson, Arthur, that there are difficult, complex situations that we are really constantly grappling with and trying to learn from.
Thank you, Neil. Gary, was yourself, wasn't it?
Thank you, Chair. Gary Jones from Support Staffordshire. I suppose observations really rather than questions. I'm much more familiar with the Safeguarding Adults Partnership Board, which is on the face of it, a much sort of broader partnership, I guess, which is quite a distinct, seems to be quite a distinct difference, where Children's is very focused around the work of the three statutory agencies. And I suppose reading the report, it's really clear that there's lots of very active work going on, lots of transformation, lots of learning, lots of restructuring. I suppose what I didn't get, and I almost feel I'm saying this more as a parent really, is I don't get that clear sense of, are children in Staffordshire suffering less harm this year than they were last year? And I wonder whether that's sort of, it's just an observation really, I guess, perhaps for you as you're working towards your next annual report for a year in which you're responsible for it. That's the kind of ultimate question really, isn't it?
Yeah, I'm very happy to respond to that. I think one of the things that we do need to evidence is impact. We do need to be able to pull on all of the evidence that's available to us, including, as I mentioned, the voices of children and young people in that that context is measuring how successful the arrangements have been, and therefore what impacts they've had for children and young people. So I'm very aware of the next annual report making some comment and some conclusions around how these arrangements are impacting children and young people specifically. Certainly we have some evidence of that through some routes, but not through all. But I think that's the focus, I think, for the annual report that we're just about to start the process in, and I'm very happy to be able to feed that back next time we have the report, with hopefully some much more focused conversations around how has this actually made a difference.
Ian, thank you very much for that. Thank you for coming and presenting that. And the two recommendations that the board have been asked to do are to receive the report and to consider or comment on the progress that the board has made. And I think we've had opportunities to address those. So, Ian, thank you for your time this afternoon.
My pleasure. Thank you.
Thank you. So, ladies and gentlemen, we'll move on to the next item, which is the JS&A review. Thank you very much for excellent timing.
Thank you. This is actually just a really short report, so I don't know, excuse me, if people are aware, we need to produce a JS&A. It's a statutory requirement for the organisation and health as well. I think the last time that one was produced at a sort of locality basis was quite a long time ago, so this is really to try and refresh this and really reshape it to be a bit more interactive, I suppose, than what we've had before. So what we're proposing to do is to have, like I've just said, a more interactive tool so that it's displayed when you log onto a website, and what you'll be able to do is choose sort of Staffordshire or look at different geographies, so maybe the districts and wards to begin with. So we'll be able to populate it because there's quite a lot of open source data out there that we can populate this with, and it will enable people to sort of look at different kinds of health inequalities and maybe some of the trends in their area, whatever's contained in the open source data, and we think's good to put in some of the chapters. So I've been having a look at various versions of these on the internet that other areas have done, and I think we found some good ones which has got some chapters which sort of follow the life course really, sort of children, young peoples, adults, older people, that kind of thing. Different themes, sort of population, demographics, and then things like different inequalities as well. So we thought we'd start with that as a sort of basis, and then in the future we can do more to add our own data and own information to make it better over time. But I think we really need to get to a place where we start from that sort of basic stuff. I think from looking at what we've done in the past, a lot of it was actually populated by the kind of data that I've just described. So it's just really to make this, instead of having pages and pages of a PDF, which is difficult for people to read, something they can click on, and there's a a description at the side of what the data's saying, but there's actual charts and tables and stuff that people can pull out and use. Like I say, it could be a really big project over a number of years that takes a long time, but I think the first bit that we need to do in the shorter time scale is to get that basis up and running, and then we can do some really useful work. So to date, we've had sort of set up a steering group excuse me, to look at how we're going to do this. I think we'll probably have to look at doing this in combination with Stoke as well, because the ICB are our partner and it covers the two areas. I personally think that's the benefit for both of us, because there's things that we you know, the borders of our area and their area sort of, you know, they're right next to each other, and especially if we're looking at things like service provision, it's useful to be aware of that. So, and I think from the ICB's perspective, they obviously want to see the whole patch as well, to make sure that they understand inequalities in a broader sense around the whole county. So we were aiming to get the sort of first bit of this ready at the end of December. We are currently looking to resource this. It's quite a complex piece of work, and so we're trying to get hopefully some resource in to set this up for us. What I am really keen to do though is make sure that whatever resource we get in, there is training and support for our staff and staff in the wider economy to be able to take this on and run with it, so we can develop it further going forward, because I don't think there's much point doing something if you're just having to get people in all the time, and obviously there's a cost involved in that as well. There'll probably be some cost in the licensing of actually having this product so that people can view it and see it. But I think it'd be really useful also for colleagues in the district, so you know, there's people be able to drill down and see what's going on at districts and maybe in some of the wards. And something I would like to develop in the future is maybe sort of sub-district geographies that aren't quite as small as wards, so they're a little bit more meaningful in terms of analysis and being able to do comparisons, because I'm aware that in Staffordshire with some of the populations that might not be possible across all areas. But really that's kind of just an outline of what it is we're proposing to do. Excuse me, I've had a bit of a virus last week. Yeah, so if anybody's got any questions about that, happy to take them.
No, thank you very much for that. I think deciding our priorities and, as a board, and what we're going to do, I think it's absolutely essential, you know, that we follow the information that, and the intelligence and that we get. So from that perspective, what you're doing is, I think, very much welcome. And I would imagine from an ICB perspective, they would want it to include Stoke as well, and I absolutely get that. So any questions of Emma at all? Okay, if that's a big fat no. I would take it that we all support the development of that, and I think we all do. So Emma, thank you very much for that. That was short and sweet. Thank you. So moving on to the next item, which is healthy ageing follow-up from March. Richard, I understand that you're going to do a brief update on this item.
Yes, Chair, thank you. So just a quick update. There were a couple of healthy ageing workshops. Thank you to NHS colleagues for chairing and leading those. They were very well attended, some really good discussions. So the outputs of those are going to inform a healthy ageing plan, which will come back to us in due course. I've been asked if anyone's got any specific questions about those, if they could feed them back to Vicky or Tilly. I'll do my best to take any today, but otherwise, if anything comes to you, feed it back to those two and we can include it in the plan. Thank you.
Any points or any questions of Richard or to fit in? No? Okay, thank you very much for that. So in that case, we will move on to any other business of which I've not been notified of anybody, but if anybody has anything they wanted to raise, and again, that looks no. So in that case, we move on to the forward plan. John.
Yeah, the forward plan's on the agenda right at the end of the papers anyway, but just to remind people, the priority theme next time round is health in early life. So Karen, Coca and Natasha will be coming along to do that one, hopefully. We've also got Better Care Fund on the plan. Health Watch is on again, actually, so co-production. So And if necessary, we'll pick up JSNA if there's need for an update on that too. And potentially, if there's an update from if there's actually a plan from the Healthy Ageing workshops, we'll bring that to the board as well.
Okay, John, thank you very much for that. So thank you everybody for your attendance today. And we look forward to seeing you all after the summer on the 7th of September. Thank you very much for your attendance.